In which case, if I could please invite the first speaker, José Luis Bas, to come and present their paper on incidence of cardiac anomalies in congenital vertebral deformity. Thank you very much.
I think the presenter is Gonzalo Mariscal. Thank you.
Okay, so hello everyone. My name is Gonzalo Mariscal. I'm an orthopedic surgery resident at La Fe Hospital of Valencia in Spain. And thank you very much for the scientific committee for accepting this work. We have nothing to disclose. So there are few studies that analyze this condition. It would be very interesting to study this condition, to have an appropriate conversation with families and patients and to optimize the patient's condition before spinal procedures. So the present study aims to investigate the real incidence of cardiac anomalies in patients with congenital scoliosis and to assess which factors increase the occurrence of these anomalies. We follow the BritSpine guidelines and PICOS strategy. Some of the exclusion criteria were that we focus on postnatally diagnosis. This is the search strategy, and we were very limited with the data, with the information offered by the studies. We collect baseline data, the associated anomalies, malformation, among others. We use the minors criteria to assess the risk of bias, and we follow the Cochrane recommendations to do the statistical analysis. We use the Review Manager software. We also made subgroup analysis and funnel plots to assess heterogeneity. This is the PRISMA flow chart. The first search yielded 48 studies, but with the exclusion criteria, we finally include 9 studies and approximately 3,000 patients. Almost all of the studies include a cardiac ultrasound, and minors criteria show the acceptable quality of the included studies. This is one of the most important slides of the work. This is the real incidence of cardiac anomalies, varied between 17 and 25%. The most frequent anomalies were mitral valve prolapse, valvular anomalies, because most of the studies did not specify which anomaly they were talking about, followed by atrial septal defects, among others. So this could be a guidance for the ultrasound practitioner, because they need to rule out first the most frequent anomalies. There were no differences regarding the region or diagnosis age, but they were more frequent in Europe and patients diagnosis older than 10 years. The incidence of female was significantly higher compared with males, almost 60%. When we compare the malformations, formation defects show a higher incidence, a significantly high incidence, with 41% approximately, followed by 25, 24, and 20 respective mixed and segmentation defects. When we compare the associated anomalies, we could only compare the intraspinal associated anomalies, and 30% of the patients with cardiac anomalies present one occult intraspinal abnormalities. This is for the meta-analysis, but when we systematically review little case series or case reports, we can obtain these recommendations. First, it's important to correct this deformity, but severe correction could produce a cardiopulmonary decompensation. Important to consider renal anomalies due to the metabolic disturbance that impair circulation and, of course, heart function. In patients with Fontan circulation, that is the connection of the two cava veins, they have an alteration in the coagulation, and patients with single ventricle defects had an increased breathing due to the high vein pressure. If we compare our postnatally incidence with prenatally, the incidence was same, almost 26%, but they have different type of anomalies. These anomalies were more related to the right ventricle. So a force in prenatal ultrasound could be made to find valvular anomalies, as is the most frequent postnatally, that is early detection. So in conclusion, the real incidence, the high evidence with meta-analysis, showed that the real incidence of cardiac anomalies in congenital scoliosis was 21%. Mitral valve prolapse was the most frequent. We should have guidance for ultrasound practitioners. Females and formation defects have had a higher incidence, and future studies should focus on what is the exact risk of these anomalies in spinal surgery to study maternal or familial risk factors or biomarkers that directly link to these anomalies. We would like to acknowledge Omedics for the statistical analysis. Thank you very much.
Fantastic. Thank you, Gonzalo. Fantastic study. Do we have questions from the audience?
Could I ask a question? Do you have an idea of what proportion of these anomalies were known of before and how much were picked up as part of screening to prepare for surgery?
I don't hear very well.
Sorry. How many of these anomalies were known of from before or were then picked up when the patients were being screened for their surgery?
We found, you mean prenatally?
Yeah.
26%, almost it's the same. But they found very little proportion of valvular anomalies. And that is interesting because it's more frequent postnatally. So if we detect or we put more attention during prenatal ultrasound, focus on these valvular anomalies, probably we could correct or have an early detection in the future postnatally.
How many of these patients had surgery, and what age did they have the surgery for the congenital spinal anomalies?
So I think the sound here is very bad. I don't know.
What age did they have the surgery?
What day?
Age.
Age. The age was in the mean about 12 years old of the whole cohort, but most of the patients received the diagnosis after 10 years. Most of these patients were diagnosed in reference hospitals, but a lot of patients came from countries that they do not have so many resources. So this is why the mean age was very high.
And do you have an idea of how many of these needed cardiac procedures before they had their surgery?
We could not compare. This information is just in renal anomalies, but in cardiac anomalies we could not compare. Just case reports, case series. So this is why I emphasize in future studies to focus in this, because this is the real outcome for us, for the spinal surgeons or doctors.
Thank you.
Great.
Thank you very much.
Thank you.
Thank you for your presentation. Next up is Jennifer Ward presenting a systematic review of the certainty of neuropathic pain in medication trials for low back pain or sciatica, a meta-analysis of efficacy subgroup by certainty or neuropathic pain.
Hello everyone, thank you for inviting me today. I'm an advanced practice physiotherapist and a prescriber, and this systematic review came from a clinical question: which of my patients are most likely to respond best to neuropathic pain medication? I looked to the literature, but I couldn't find the answer. We know low back pain and spine-related leg pain is heterogeneous. There are many various different pain mechanisms that we see in this patient cohort, including nociceptive, inflammatory, and particularly neuropathic. Neuropathic pain is a common condition in this cohort, but prevalence rates vary, ranging from 30 to 70% depending on how it's diagnosed. And that brings us to the challenge that neuropathic pain is hard to identify in this patient cohort and is often not considered in clinical trials. The Neuropathic Pain Special Interest Group have produced a grading criteria to help us identify possible neuropathic pain based on pain descriptors and screening tools, probable neuropathic pain based on bedside sensory examination, and definite neuropathic pain which is confirmed with diagnostic tests. And this has recently been updated to be relevant to specifically patients with low back pain and leg pain, and the publication is pending. What do the recommendations advise about managing neuropathic pain with medication? It's conflicting. The International Association for the Study of Pain suggests a range of SNRIs, tricyclic antidepressants and anticonvulsants, but likewise we know that the NICE guidelines have recently recommended against prescribing neuropathic pain medication. And similarly, we've seen that from the American College of Physicians. Why do we see this conflict? The evidence of efficacy for these medications is generally low in systematic reviews and meta-analysis. But my concern was that many of these trials didn't actually include patients who appeared to have neuropathic pain. So the aim of the study was to identify how is neuropathic pain identified in clinical trials and to determine if subgrouping based on the certainty of neuropathic pain would influence the efficacy of the medication. So we followed the systematic review process, we registered in Prospero, we include randomised controlled trials and crossover studies, including all of the above-mentioned medications. We had some exclusions, we searched a range of databases and grey literature, and 2 reviewers screened the full-text articles, rated the risk of bias, judged the certainty of neuropathic pain at a study level, extracted the mean values and standard deviations of pain and disability outcomes. You can see from the PRISMA flowchart we have more than 2,000 extracts, and we reduced this down to 25 clinical trials and 1 post-hoc analysis. You can see here it's obvious that many clinical trials did not clearly identify the certainty of neuropathic pain. 24% didn't give us enough information about baseline characteristics or inclusion criteria to make a decision. 36% had unlikely neuropathic pain candidates because they actively excluded patients who had symptoms of neuropathic pain, such as pain descriptors and bedside examination findings. And only a small proportion managed to meet the probable or definite criteria within the grading criteria. You can see these are our outcomes overall for all pain medications. And you can see that at short and medium-term outcomes, we see small differences in favour of treatment versus placebo, but these differences are less than 10 points on a 100-point scale, so not particularly clinically meaningful. When we split this down by certainty of neuropathic pain, according to the clinical trials, we can see there is a trend towards improved outcomes in trials that had definite neuropathic pain in the short term. But we did not see the similar trend happening in medium-term outcomes. Looking at disability, we again see a similar trend happening for trials with possible, probable and definite neuropathic pain in disability in the medium term. If we separate these out by pain medication types, we can see there is certainly a trend towards improved outcomes for tricyclic antidepressants in patients who had probable, possible or definite neuropathic pain. We did not see this same trend happening with SNRIs or gabapentin. However, the challenge is that there was a high risk of bias across many of the studies. We had large confidence intervals and high levels of heterogeneity. So the further research is required. But this systematic review does suggest a trend towards improved outcomes in patients with definite neuropathic pain, and this trend might be leaning more towards patients taking tricyclic antidepressants. I'd like to thank my NIHR pre-doctoral clinical academic fellowship supervisors, Professor Anina Schmid, Colette Rydehall, and Professor Paula Kirsten, as well as my second reviewers who've helped me to bring this systematic review together. Any questions?
So, given the small benefit you had, has it answered your question and changed your practice?
It has answered the question in that probably my overall question was that I didn't think that the clinical trials that existed currently looked at the right cohort of patients. So it's answered the question, in my mind, is there further research that's required, and has led me to think about preparing a PhD application to explore that further with this particular cohort of patients. But at the moment, I don't think we can certainly say that clinically we can recommend a particular type of medication for a particular cohort of patients yet, but it does suggest a signal that might be worth exploring further.
Sorry, could I just ask? I think it's always really, in some ways, quite disappointing when we sort of look at these studies where we see so much work has happened, but the analysis then ends up being on such a small number of those studies because of the quality of those other studies. And we've been talking about big data earlier and how so much of that data is then lost in the analysis in the end. Do you think that we actually are looking at just a really small treatment effect, or do you think it's because we haven't got the bigger picture?
I think we haven't got the bigger picture, and I think we just haven't got the inclusion criteria right for many of these trials, and we need to think about that baseline assessment of neuropathic pain. Even if you're not restricting your inclusion criteria right the way down to patients with definite neuropathic pain, because the challenge with that is then it's very difficult to recruit patients when you're seeing a very mixed pain presentation in a clinical setting. But I think even if we can just gather some of that baseline data and start to identify some of the associations in response to medication compared to neuropathic pain features, I think we should start to see some improved outcomes. Because at the moment, the research for managing low back pain and leg pain conservatively is really depressing, actually, for patients, that not much is out there that can really help. So I think this is a really important task that we need to try and identify that personalised care approach for these patients.
And on that note, thank you very much. Our next talk is, a speaker is Christine Lemaitre, and she's going to be talking about the PCRX201.
Thank you. So thank you very much for the opportunity to talk today about a potential gene therapy approach for intervertebral disc degeneration. So just to mention, first of all, the conflict of interest. So this work was funded by the company who have the viral vector that we're investigating. So it's initially funded by Flexion, who's then subsequently been taken over by Parcera. So why are we interested in disc degeneration? So disc degeneration is a major cause of low back pain, particularly in those individuals that have the highest years lived with disability. So in those individuals which are 55 and under, show a very strong association of disc degeneration with low back pain. And I must say, I also have an invested interest, because this was my spine with a large herniation, so I need a treatment as well. So we're looking at a potential target of interleukin-1. So interleukin-1 is produced by the cells of the disc themselves. This isn't an inflammation effect. This is an actual cytokine that's produced in the disc and drives a number of the features of degeneration. It leads to the increases in degradation enzymes, decreases the production of matrix, drives a whole host of cytokines and chemokines, and also drives factors which can draw in the nerves and blood vessels, making the disc painful. In addition, if you take away the natural inhibitor of interleukin-1, known as interleukin-1 receptor antagonist, which is encoded by the IL-1RN gene, you get spontaneous disc degeneration. It's also been linked to the cellular senescence that you experience within accelerated disc degeneration. So can we actually use this as a target for gene therapy? Some of my prior work, we looked at gene therapy a number of years ago with an earlier vector, and there we showed that only healthy cells were able to transcribe the protein IL-1 receptor antagonist. And when we transferred this into explant cultures, it was only the healthy cells that showed a positive effect. So this isn't very useful, because you can't really get healthy cells. People don't want to donate those cells. So then I was approached by a company in America who have an alternative vector. This is based on a helper-dependent adenoviral vector, and it's driven by the NF-kappa B promoter. So this means if there's lots of interleukin-1 around, this will get promoted more, and you'll get a further increase of the gene expression. And it's currently in phase 1 clinical trials for osteoarthritis, so the safety profile is already known. So here we wanted to look at, so if we take cells from a degenerate disc, can these cells now transcribe and produce the IL-1 receptor antagonist? So with this, in vitro, we did a number of phases of testing. First of all, testing these in a simple monolayer culture where you grow cells out on plastic. And here we showed that even the cells from degenerate disc, and this is in 7 different patients, we got excellent transfection and good production of IL-1RA. If we take this into a 3D culture system, where you can mimic much more closely the phenotype of the disc cells, again, we got good transfection capability, and we actually didn't see much of an increase when we treated these cells with IL-1. This is most likely because these cells are already producing lots of IL-1. And this was maintained for the 3 weeks in culture, so you can actually get longevity of production of the IL-1RA within these culture systems. If we take this to an ex vivo culture system where we have little pieces of disc tissue kept alive in culture, and we inject the virus directly, we also see excellent transduction and production of IL-1RA within the cells within the tissue. And this you can see with an increase in number of cells across the whole tissue region that express the IL-1RA protein. So what's the effect of this IL-1RA that we're driving? So in the alginate cultures, we see excellent inhibition of catabolism with decreased production of a number of cytokines, interleukin-1 and interleukin-6, and decreased production of matrix-degrading enzymes, MMP3 and MTS4. This was also seen if we take the culture media from our infected cells and put those on fresh degenerate disc cells, we also see you get a paracrine effect, where it can pass on the effect to the adjacent cells, decreasing catabolism in the cells surrounding. And if we look within the tissue, we see a similar effect. So across the tissue, you see decreases in cytokine production, decreases in VEGF, which will reduce the blood vessel growth, and decreases in matrix-degrading enzymes, and the release of aggrecan into the culture media. So this means there's less aggrecan being broken down, and aggrecan is one of your matrix proteins in the disc. If we look at the expression within the tissue, again, we see less cells expressing the catabolic factors, IL-1 and VEGF, less of MMP3, but more aggrecan, so that's a positive factor. So to conclude, we know that interleukin-1 is an important pleiotropic cytokine within the intervertebral disc, driving lots of the features of disc degeneration. So if we can induce the inhibitor IL-1RA, we can inhibit catabolism, promote anabolism, and potentially regenerate the disc. So I'd like to stop there and thank particularly the surgeons. Without donating the tissue, we wouldn't be able to do this work, and I'm happy to take any questions.
Thank you, Christine. Christine, could you talk a little bit about your vision? What would gene therapy for disc degeneration look like in clinic? What are challenges, opportunities, risks?
So interestingly, I started looking at gene therapy back in my PhD days, and that was when the very unfortunate event occurred within a leukemia patient in France, and then gene therapy went out of favour. It is now coming back into favour, and there's a lot more safety profile for gene therapy. So I think the idea would be that if we can demonstrate you can do a simple injection of the viral vector, and that's taken up by disc cells, this will enable a very fine bore needle to inject in the gene therapy and then basically turn the cells back into a more anabolic effect rather than catabolism. We also need to probably look at the mechanics and things like that as well within the disc, but we've got other strategies for that, which we'll talk about in other talks.
Thank you.
Thank you.
Thank you.
Next up is Alvin Jones, please, talking about a randomized controlled trial for posterolateral fusion.
Thank you very much for accepting this paper for the presentation. I'd like to thank the authors of the paper who are from Holland. I've been asked specifically by Kuros, the company, to assimilate the white paper and to present their early results. My disclosures. So preclinical studies, the graft was used and put into a canine model in a muscle pouch without any growth factors or cells added to it, and at 12 weeks this was explanted. And for people who don't know histology, the red bits on the left-hand side of the screen is actually mature bone, whereas blue and black are material and fibrous tissue. So in the magnetos group, there was good formation of bone in the center and also to the sides. Comparing it to different graft that we used in the study, you can see far more dark and blue areas in the other graft. This went forward to doing a sheep model where they did a posterolateral fusion, and they compared at 12 weeks again the grafting in the autograft, other synthetics, as well as the magnetos, and the histology slides are reasonably convincing to show bony fusion across the posterior bony elements. So this then transferred through into a prospective randomized controlled trial. It was multi-center. It was funded by the company. It was in respect of lumbar spine posterolateral fusion. It was 10 cc's of magnetos on one side, autograft on the other side. I'll come to the autograft later on. Primary outcome was basically fusion with fine cut CT in 3 planes in the posterolateral area. And the statistical design was to show non-inferiority compared to autograft. So there's 100 patients. So far, 50 patients have reached a year. There's 20 males, 30 females. The usual diagnosis with regards to why we were instrumenting: deformity and instability. 2/3 were 1 level, a quarter were 2 levels, and there was a few of 3 and 4 levels as well. So results, as they reviewed them at the 12 months, the overall fusion rate was 76% in the magnetos group, 44% in the autograft. This tended to be increased with the increased number of levels. So on that result, and this was for levels, so there were 71 levels, 1.4 per patient, This was suggesting a better outcome of fusion in the magnetos, but certainly I would say it did not show an inferiority as compared to autograft. Per subject, there was 50, and again, the results show an overall fusion rate of 78% in the magnetos, 42 in the autograft, and as I've mentioned already, it seems to be increased the more levels you try to fuse. Case example, this is an L3 to L5 fusion. There's a cage inserted L4-5. Magnetos is on the right side, autograft on the left side. At 12 months, you can see how at the L4-5 level on the left, the bone graft hasn't taken, but the rest of the levels have fused. The group in Holland had done a previous study in 2020 using a different synthetic, which was Atrax putty, and because the study design was identical, they were able to compare results, and their comparison was fusion rate of 76 in the newer synthetic versus 55 in the previous one. So in conclusion, of the 50 patients that are being presented, the graft itself seems to be acting well and giving a reasonable fusion. It certainly doesn't show an inferiority with regards to autograft. As a standalone bone graft, comparing it to the previous synthetic, it seemed to have better outcome in a similar trial. And I think, in conclusion, from the results as presented so far, I think the magnetos would be a reasonable bone extender or standalone graft to use in spinal fusion surgery. Papers were referenced, and thank you.
Your figures for the autograft fusion are very low.
Yes.
Is that because we are bad at assessing fusion with autograft and you're assessing it more stringently, or whoever's done this isn't very good with autograft, or
when I first, because I was asked to, because I've been using this graph for 5 to 6 years now, I was asked to see and look at the white paper, and my first impressions were, this looks terrible. And when you dig down and look at different studies, this percentage is not different to a lot of other studies. My gut feeling on the autograft, because they were using 10 cc's, how did you estimate that? They were putting it into a syringe and compressing it to see if it was 10 cc. But I would say there's probably going to be some air in that as well. And also, it was approximately 50% of that graft was iliac crest graft versus local bone. And looking at other papers, I think probably the volume was not enough. And probably the volume of iliac crest graft was not enough to make these percentages look quite poor. I think the grafting technique is appropriate because obviously it's fused on the synthetic side, so their preparation of the bed seems appropriate. But I think it's just the volume and what graft was used, I think, would answer that question.
Thank you. Are you collecting any safety or patient-reported outcomes?
They have looked at adverse events. In this group, there was 2 screw loosening, 1 screw breakage. They were the usual. They looked at ODI as well, but it was too much to put in all in this. But there were significant. There were the usual adverse events with regards to nerve pain, dural tears, which were not above the usual percentages. But yeah, they have looked at that, and that'll come out in the paper when it's completed.
Thank you very much. I'd now like to invite Muhammad Abdul to present the paper on Glasgow vertebral artery anatomical study.
Good morning. Thank you for having me. I'm Abdul Sadbi, current college spine fellow in Leeds, and I'm presenting this work which is predominantly conducted when I was a senior registrar in Glasgow. It's an anatomical study looking at the vertebral artery anatomy utilizing CT angiograms. Briefly, regarding the anatomy, vertebral artery classified into 4 segments, V1 to V4, V1 from the subclavian to the foraminal transverse area, that is typically C6, V2 with the transforaminal, V3 around the craniocervical junction, and V4 is the intradural segment. We know that there is significant variation in the course of the vertebral artery. And this variation does have the implication on clinical practice, particularly from a spinal surgical perspective, as well as it's heavily dependent on the ethnicity or the population under study as any other vascular malformation. So to be able to inform our practice and quantify these anomalies, we've elected to conduct our own study. So the options were either cadaveric study to study the vascular anatomy or angiographic study, and because of the shortcomings of the cadaveric studies, we've elected for the CT angiograms. So the aim is to identify and quantify the variation in the vertebral artery course. As spinal surgeons, we've only looked at the V1 to V3 segments. This has been through retrospective analysis of patients. Just to put this into context, before our study, the largest population study, the Polish study, which included 1,800 patients. So our study nearly doubled that number, which makes it the largest in the literature. CT angiograms, just to relate to the bony anatomy as well, and the first 3,000 were included. I'm not going to go to the details, so there is a protocol done by one of the senior authors, so the neuroradiologist, and the data analysis was done by a data scientist with a PhD student in Strathclyde University. We've essentially included all patients, and the exclusion were merely for the uninterpretable scans, or they are not including the aortic arch to the vertex. Fairly similar cohort in terms of gender distribution, slight male predominance, and a wide age range, as you can see. We've looked at over 6,000 individual vertebral artery. Briefly going through the results, origin of vertebral artery in our cohort, predominantly as in line with the literature, is subclavian. However, we found the left vertebral artery coming off the aortic arch has more incident than reported in the literature in the Scottish population. So it's 10% with our cohort compared to 5% in the literature. Interestingly, for the left vertebral artery aortic arch, it was found to be associated with the indication of scan being left-sided vertebral artery dissection. Further analysis is taking place into that. Level of vertebral artery entrance to the transverse foramen, as you expect, it's predominantly C6. Again, in contrast to the common literature, C7 is not the second commonest entry point, it's actually C5. And in fact, we did not have, out of this cohort, we did not have any left C7 transverse foramen vertebral artery on the left side. Another observation which was interesting, whenever there is the longer V1 segment, i.e. it enters the transverse foramen above C6, it courses more medially with a distance next to the ancovertebral joint, essentially where you put your retractor in. This is an interesting concept, and again, further quantification of the distance is being now taking place. We've identified a new triad of anomaly in the vertebral artery around the craniocervical junction. Whenever any of these takes place, it's associated with the second two. So if the vertebral artery is medial to the C1, C2 joint, then it compulsorily skips the transverse foramina on the ipsilateral side, and it goes below rather than above the posterior arch of C1. Essentially, this is where you want to dock for your C1 screw, and this is affecting your C2 lateral mass or part screws as well. So 3D reconstruction of the same. So if you look on here, the pattern is skipping the transverse foramen of C1, it's curving medially to the C1, C2 joint, and it is below rather than above the C1 arch, which is affect your dissection as well. Here is a slightly hypoplastic vertebral artery on the left, but again, it has the three anomalies medial to the joint, below the arch, and skips the transverse foramen on that side. So we've also looked on dominance, duplication, and fenestration. Again, in contrast to the majority being left-sided dominance as in the literature, the Scottish population had almost 50% of codominance, which is if you have a misplaced screw, you'd rather to have it in the Scottish population with us because there is a codominance of the vertebral artery. There is also very rare incidence of duplication and fenestration in our cohort. So in summary, association between the non-subclavian origin of the vertebral artery and symptomatic vertebral artery dissection, variation in the V2 course is very rare. C5 foramen transversum is the second most common entrance level. A relatively medial course under longus coli was noted for the longer V1 segment, and in an abnormal V3 course, look for the Glasgow triad we're on the manuscript writing stage of this study at the moment, and hopefully it will be published very soon. Thank you very much.
Any questions? Can I ask, when you've actually spoken to any of your colleagues who've been doing this type of surgery, were they aware that this anomaly was there before you did the study? So just speaking to people who often operate at and around this level, had they noticed this anomaly themselves, which then led you to look for it, or did you pick it up incidentally?
So, so one of the senior authors is a craniocervical junction surgeon. It's been identified that sometimes the vertebral artery course is where you want to put your screws, i.e. below the arch or within the lateral mass. But to link it with the other two anomalies was not necessarily found in the literature. And this was merely brought up by the data scientist, actually, rather than us looking for it. So we fed them the data with the data entry points, and they get that information.
Thank you.
Hello. Well, an interesting study, but not to do with surgery. We know that people who present with head and neck pain sometimes are presenting with vertebral artery dissections, pre-ischemic dissections. I'm just wondering if you've thought about the relationship between altered anatomy here and the incidence or cause of spontaneous dissection in the neck, vertebral artery in the neck.
So the scans that we looked at were for the health board, all CT angiograms performed for whatever reasons. The indication of the scan was one of the data entry points. However, what we identified with an anomalous origin of the vertebral artery associated with dissection. This has also been described before in terms of changing the hemodynamics of the vessel. So coming up from the aortic arch, higher pressure straight to the vertebral artery rather than going through the subclavian. And the dissection segment tends to be wider for a more proximal origin of the vertebral artery. But again, it's an identified pattern or defined pattern before when an anomalous course for vertebral artery dissection. I don't know if that answers the question. Okay, thanks.
Excellent. Thank you very much.
Thank you. And then we have Claire Ryan, please, presenting a qualitative study on why patients attend the emergency department with low back pain.
Thank you. Each month in the UK, around 50,000 people attend the emergency department for low back pain. This is despite clinical guidelines that recommend that for most, low back pain should be managed in primary care, and UK healthcare policy that prioritises reducing emergency department attendances. In this study, we therefore sought to explore why people attend the emergency department for low back pain and to consider how this population might be best or alternatively managed. This was a cross-sectional qualitative study. Our sample comprised 47 adults who had recently attended the emergency department for low back pain, and we included people with all types and durations of low back pain. We recruited our sample from 4 UK NHS emergency departments and sampled purposefully for maximum variation based on low back pain and demographic characteristics. We collected data using individual semi-structured telephone interviews, which lasted an average of 45 minutes. We audio recorded the findings, transcribed them verbatim, and analysed the findings thematically based on Brown and Clark's reflexive thematic approach. Our overarching explanation was mitigating perceived vulnerability. The vulnerability that resulted from low back pain, together with issues of access and confidence in primary care, meant that people perceived that they had no option other than to attend the emergency department. People perceived that they were vulnerable due to low back pain due to its severe and disabling nature and the escalating or unresolving trajectory. Also because of the adverse impact that low back pain had on people's sleep and on their physical, psychological and social function. This was a particularly distressing pain that made it difficult to walk, to sleep, to work, and to care for children. People also worried about the cause, and this related to particular concerns about damage, as well as the uncertainty as what the problem might be, and also to visceral causes. Finally, people worried about the future consequences, so the implications for their future, including the impact of persistent symptoms. People therefore sought urgent help to address the pain, to exclude a serious cause, to better understand the problem, and to minimise the impact both in the current and in the future. It was clearly evident that people had a driving need to take action to mitigate their vulnerability, and that they felt a right and responsibility to use healthcare to achieve this. For the majority, the options to mitigate vulnerability were perceived to be the GP or A&E, with urgent care with 111 used for urgent advice only. Issues of access to and confidence arose, however, when accessing primary care, and this related to people's difficulty in accessing an urgent face-to-face appointment. Confidence also arose, particularly around whether primary care would provide the optimal management for low back pain, and there was a wider loss of confidence in primary care's likelihood of providing responsive care. In contrast, A&E was understood to provide guaranteed access to a same-day urgent face-to-face appointment. It also provided access to hospital services such as investigations or admission, and provided enhanced support to attend, which was particularly important to those most disabled by pain. Finally, around half of participants told us that they had been advised by a healthcare professional to attend. A&E was therefore perceived to be the only option, and whilst people understood the emergency remit of A&E, mitigating vulnerability was their priority. Our findings suggest the need to shift responsibility away from the individual who's been unable to meet their needs using services other than A&E, and most importantly, that we take time to consider how we might address the issues of access and confidence in primary and urgent care. Finally, as vulnerability is known to affect those with health inequalities disproportionately, it's important to consider particularly how these issues of access and confidence might be addressed in this subpopulation. Thank you.
Thank you so much. Really, really nice study, and obviously showing the importance of us getting better there. I'm just wondering, is the GP setting the best setting to do that? Because again, it's a 10-minute appointment. Sometimes it's a 2 weeks wait, or even longer in some settings. Do we actually need to provide other kind of pathways for these patients? Would they have been happy to attend a virtual appointment, or did they want a face-to-face appointment? Could that be done by first contact practitioners, for instance, instead of by GPs, because that might be a bit more, because clearly what they want is more time as well, right? More for explanations, etc. That is quite often difficult in a 10-minute setting.
Thank you. So that's really interesting. It was clearly patients' priority to get a face-to-face appointment, and that was absolutely paramount. And that came out particularly because we collected data between the first 2 waves of the pandemic when face-to-face appointments were a real issue. And that face-to-face appointment was really key to people feeling that they needed to have their day in court, if you like, to get the severity, the impact across to the practitioner, and also to have the chance to be examined. So face-to-face was absolutely key. In terms of time, that was also important. Patients talked about the telephone conversations they had with GP, and they recognised the pressure GPs were under, and it therefore felt like a really rushed conversation, so time was also key. Is the GP the best place to manage it? It was interesting that patients really understood their options to be GP or A&E, and therefore there would be an issue with recognising where other services existed for patients. At this particular moment of crisis, it was one option or the other. But there's absolutely, it would seem, the potential for places like FCP to provide that kind of service that would maybe have the time and patients appreciated when they did actually go on to see a physio or have someone that spent time with them in A&E. But I think there's key issues around patients understanding services and where best to access them.
Thank you very much. I see there's some other questions, but I'm afraid you're going to have to take that up in the coffee break. Thank you very much.
Thank you.
Okay, and then we have Fiona Saunders, please, with the association between osteoarthritis, back pain, and sagittal spine shape, an analysis of the UK Biobank. Thank you.
Thank you, and thank you for the opportunity to present this work. As we have nothing to disclose, we know that back pain and osteoarthritis are big problems, and our particular group is particularly interested in how the shape of the vertebral bodies and the spine could be used to quantify what's happening in disease. We've used these statistical shape modelling technique quite a lot to quantify the variation in shapes in particularly complex structures such as the hip and in the lumbar-lateral spine, and looked at their associations with disease in previous studies and shown that they're particularly interesting associations. In this study, we've used data from the UK Biobank, which is a large population-based study of health, and as part of their clinical assessment, the participants undergo DEXA assessment for bone mineral density, and we've used the lateral spine study images from this study. So the aim of our study was to explore the relationships between osteoarthritis, chronic back pain, and lateral spine shape in the UK Biobank. So we've used the lateral spine scans. There are other scans available, and these are IDEXA scans. The lateral spine shape was described using a 341-point template. The points on T7 down to L4 were placed automatically using a search algorithm and then adjusted manually. The superior margin of L5 was annotated manually. This is because we don't see L5 fully on every single scan, so we would just use the superior margin. Using principal components analysis, we analysed the first 10 modes of variation that came from this analysis and accounted for nearly 90% of the total mode of variation. Self-reported back pain of greater than 3 months duration and osteoarthritis were self-reported by participants via a touchscreen questionnaire at their clinic visit. We used logistic regression to investigate the associations between the modes of variation in our study, back pain and osteoarthritis, and these were adjusted for age, sex, height, weight, and total spine BMD. So in our study, we have around 4,800 participants, equally spread between male and females, with an average age of around 62 years. The men were taller and heavier than women in this study. Interestingly, we found that the women self-reported around 13% of both OA and back pain compared to the men. When we looked at the associations between lateral spine shape and osteoarthritis, we found that there were 3 statistically significant modes of variation, modes 3, 9 and 10. Mode 3 appeared to be a reduced incidence of osteoarthritis, where both modes 9 and 10 seemed to be associated with an increased risk. When we looked at it, it was looked at it be a 12% decreased risk of osteoarthritis, and from our analysis, we can see that there's straightening of the spinal curvature, decreased vertebral column height, and we also observed narrowing of the spaces, particularly in the posterior aspect of the vertebral bodies in the lumbar region. Modes 9 and 10 were associated with a 11 and 12% increased risk of osteoarthritis, respectively. Interestingly, mode 9 looks to be related with the vertebral body width, whereas it's larger in the thoracic but smaller in the lumbar section. In mode 10, it's related to decreased vertebral column height, but we also observed increased space between L4 and L5 and decreased space between L2 and L3. Whether this is related to changes in disc space, at this point we can't tell from the DEXA scans. When we looked at the associations with chronic back pain, we found that there was a single mode associated, and again this appeared to be a reduced risk of around 19%. So this is one of the largest models of lateral spine shape that have been produced. We found that a loss of spinal curvature seemed to be associated with risk of both osteoarthritis and chronic back pain. Perhaps this is associated with the changes in musculature, but because these are from DEXA scans at the moment, we can't tell this. We also found that there seemed to be an increased risk of changes in osteoarthritis with AP vertebral body width and space between the vertebral bodies. One thing that we haven't attempted in this study so far is to look at a stratified analysis to determine if there are differences between the sexes, because we have obviously greater reports of both OA and back pain in the female population in this study. I'd just like to take this opportunity to thank our funders and the participants and the staff of the UK Biobank.
Very interesting presentation. I was wondering, do you know how these different shape changes link to the mechanical loading that's experienced by both the vertebral bodies and also the intervertebral discs? And do you know whether that increase, is it an increased load or lower loads that are then associated with the back pain?
We haven't looked at whether there are any changes in the mechanical. I think there is physical activity data collected as part of UK Biobank, but that's not something that we have analysed at this present time.
Thank you. You're using self-reported osteoarthritis as one of the main...
Sorry?
You're using self-reported osteoarthritis as one of the main variables. How good a variable is that, or how good a measure?
I honestly don't know at this point, sorry.
I think it's really interesting. We've just heard about how there are so many surgeons who are trying to recreate spinal curvature and get, whereas here you're seeming to show that a straightening and flattening of the spine seems to lead to reduced self-reporting of pain and osteoarthritis. Do you have any comment on that?
It's interesting. In some of our previous studies, we've shown that there seems to be an intrinsic shape of the spine. Whether that can be recreated is difficult to say. We found that people that have very straight spines differ very much from people who have very curvy spines, and whether that's recreatable in this context is quite difficult to say.
Anyway, food for thought. Thank you very much. Now I'd like to call David Roland to present on the surgical management of CSF venous fistula.
Hello, I'm David Roland. I'm a neurosurgical trainee in London with Mr. Pragsel, neuroradiologist and neurologist. We're discussing the UK's first and largest case series of surgical management of cerebrospinal fluid venous fistula. Got no conflicts of interest to declare. So CSF venous fistula are a fairly under-recognised pathology, first described in 2014. There's a fistula between the nerve root and an associated vein, often associated with perineural cyst, and there's loss of CSF out into the vein. And this results in spontaneous intracranial hypertension. And this often presents with an orthostatic headache, but can also present with Chiari syrinx as well. And due to improvement in myelography techniques, it's increasingly being recognized as a diagnosis. Initial investigation is often an MRI head with contrast, and you can get signs such as enhancements of the dura, engorgement of venous sinuses, subdurals, and evidence of brain sagging. And a burn score has been developed to find the probability of finding a CSF leak based on the MRI head. And there's a low, intermediate, and high ranking. To actually localize a fistula, you'll use myelography techniques, and the most common is a lateral decubitus CT myelogram. And you can see here that there's a perineural cyst with associated contrast going out into this vein here, and that's the point of fistulation. You can also use digital subtraction myelograms, and on the left image, this is an example of the fistulating vein. In terms of treatment, there's different treatments. There can be percutaneous with epidural blood patches, which can be targeted and non-targeted, targeted fibrin glue injections, endovascular embolization, and what we're talking about today is surgical ligation. In brackets, a percentage of the success of treatments, and endovascular embolization is improving, but still surgical ligation has a higher success rate. So ours was a single-center case series performed over 2 years. There were 12 patients in total, 58% were female, with an A range of 34 to 74. The most common symptom is an orthostatic headache, but other debilitating symptoms are less specific, like vertigo, difficulty concentrating, photophobia are also present. And you can see at the bottom that it often takes over 3 years for patients to be diagnosed since they develop their symptoms. So we manage our patients through a dedicated headache MDT with consultant neurologists, specializing in headache, consultant neuroradiologists, and neurosurgeons as well. All patients had a high pre-op burn score and often went under multiple invasive techniques, including multiple CT myelograms to finally get the diagnosis, as well as undergoing multiple epidural blood patches to try and treat their symptoms. All of these fistulae were located in the thoracic spine. So for our surgical technique, we use preoperative level marking by the interventional radiologist to mark the pedicle at the level. Then have used 2 different surgical approaches. The more traditional one is with a midline hemilaminectomy. However, we're moving now to using a paraspinal extrafascical approach. And the main aim of this is to reduce the potential damage to the spinal cord and also the need for a facetectomy. So here's an intraoperative image which shows the transverse process. The lateral aspect of the pars has been a fenestration to give access to the nerve root. The nerve root can then be medialized, and you can see below this is the fistulating vein going into the nerve root, and that's where CSF will be lost. The fistulating vein is coagulated, and then we can either ligate the nerve root at this level or wrap it to reduce the chance of recurrence in the future. So in terms of our outcomes, there were no surgical complications. Of the 12 patients, we've got MRI and clinical follow-up for 7. All have showed improvement in the low-pressure findings on their follow-up MRI scans, a significant improvement in burn score. And for 6 out of 7 patients, they had significant improvement in their symptoms, including their headache. One patient that hasn't improved is only 2 months post-op, can often take a bit more time before they get improvement. And this is just an example of the change in MRI findings you get, and you can see the pre-op, significant amount of brain slump, and then afterwards, 5 months post-op, that's resolved, and you get greater identification of all the anatomy. So in terms of our conclusions, we've developed this pathway for the treatment of CSF venous fistula in conjunction with the headache MDT, using neuroradiologists specialized in doing CT myelograms, as well as neurologists specialized in identifying these patients. We recommend it being performed in high volume centers. It's the UK's largest case series. We've developed this approach with a para-midline extrafascial approach to reduce the potential risk to the spinal cord, as well as reducing the need for facetectomy. And we've seen good clinical improvement in 6 out of the 7 patients, and radiographic improvement in all. Thank you very much.
Thank you. Apache Gulash from Preston. Well done to highlight this, because this is quite an uncommon cause and takes a long time to identify. We had 3 cases, and all 3 were done through the transvenous route embolization by the intervention rather than surgery. I was looking forward to do the surgery, but they didn't give us a chance. So I think the going transvenous route to embolize them is working well in our practice rather than surgery. Thank you.
So, yeah, I agree with that. I think in America, they've got the largest case series with the transvenous embolization, and they are having good results, and it is improving. So it'll be interesting to see how it compares. I think still the improvement you get with surgery has been higher with transvenous embolization so far.
Thank you very much. What's the threshold for repeating the CT myelogram? I appreciate that you've said it's the gold standard, but then some patients have had more than 1 CT myelogram to diagnose.
So this is really guided by the MDT. So you often see patients with a very obvious MRI head showing intracranial hypertension, and their symptoms will be very suspicious for it. And the fact that the neuroradiologists are developing their techniques of myelogram, someone that's had a myelogram 2 years ago in our unit had the subsequent one a year later, and they actually found a fistula again. So I think it's the improvement and the clinical suspicion really, based on everything.
Could I just follow up on that? So your indication for investigation for this is cerebral hypertension, as it were, or hypertension on an MRI scan. If you think about the number of patients who actually present with those sort of symptoms, what sort of percentage do you think actually end up having this pathology?
I think we don't know, and I think it will be very under-recognized because even as neurosurgeons, we see a very small percentage of these patients. I imagine in a neurology clinic, the amount of patients with an orthostatic headache is very high. So I think we don't know, but I think in a few years' time, it'll be a lot higher than we realise.
Thank you. David and I would really like to thank all the speakers for their great talks, for keeping to time, and for the audience for participating. We hope that you've enjoyed the session, and we'd like to stress that the next session starts promptly at 11:30, so if you could please be back on time for the first talks to start at 11:30. Thank you very much.